My name's Andrew Curran. I'm chairing this session. It's a great pleasure to welcome you all here. I'm the Chief Scientific Advisor for the UK's Health and Safety Executive, and I've been asked to chair this session, which is for late-breaking abstracts. So hopefully we're going to have some really interesting discussions, some really interesting presentations. We'll try and keep the speakers to time, which is 15 minutes each. Leaves us a little bit of time for questions. So without further ado, can I introduce David Goldsmith, who's going to talk to us about a follow-up mortality study of US railroad workers aged 18 to 64.
Before I start, I have just come from a session and I would like to very briefly say just two things. One is, if anyone in the room is doing work on railroad workers, I would be grateful if they would come and see me afterwards. I would very much like to meet you and have an extended discussion of what you're doing and share with you what we're doing. I do have to say that I have a couple of conflicts that I want you to be aware of. The first is that I have been supported at this conference by the Brotherhood of Maintenance Right-of-Way Workers, and I've also been supported by Georgetown University, and I think that it's only appropriate for me to make that clear. Well, let's try this. Yep. I also think it's very important for me to thank very clearly my co-author, Grace Bartlett, who is a young and up-and-coming epidemiologist, a very talented young woman. She's been very hardworking on this. And it's also my clear intention to thank the union. They have done something really quite unusual in the broad spectrum of things. This is a workers' union who have decided that they wanted to know what the epidemiology of their members looked like, and they have paid for this study, and but the words and the interpretation of the evidence are all mine. So a little bit of background. Railroad workers are exposed to a number of occupational hazards, and I have reviewed the literature, and railroad workers have exposure to noise, to shift changes, solvents, asbestos and silica dust, diesel exhaust, and especially maintenance of way workers have historically high injury rates, they have high stress rates, and they're exposed to electromagnetic fields, in addition to which they have this very broad kind of work life where they often spend time traveling to places to do work, and so in that sense they are sleep deprived as well. Until this study was undertaken, as far as I know in the literature, there have been no studies or mortality studies of maintenance of way workers, and this is the first time, as I am aware, that there's been an actual research study undertaken of this group. Now, the next two slides will give you a little tiny bit of background about the railroad exposure and some assumed health effects. They include diesel fumes, I mentioned that before, welding fumes, silica ballast, organic solvents, creosote and polycyclic aromatic hydrocarbons, polychlorinated biphenyls, and you can see on the other column are the health effects or potential health effects that have been known to be linked with these specific exposures. The second one gives us a little bit more, including electromagnetic fields, rolling equipment. Rolling equipment is highly related to traumatic injury and death, and we'll talk about that later on. Asbestos, herbicides. Herbicides were sprayed extensively on the right-of-way for many, many decades, and some of the workers who we will be looking at in the mortality analysis would have been involved in some of those activities. But today, in 2018, those jobs are contracted out and are no longer undertaken by the BMWED. So I just want to be really clear about that. And lastly, vibration and biomechanical exposures that are linked to musculoskeletal risk, carpal tunnel syndrome, back problems, and so on. And I have a very good colleague who is here today, if you have questions about that, who may be able to answer things that I certainly won't be able to answer. So in my study, the study methods that we used involved the following sets of steps. We submitted to what is called the U.S. National Death Index a list of dues-paying members of BMWED, and we asked, could they confirm whether this person has been deceased for the years 1979 up to 2014. These confirmed deaths were organized using ICD, the International Classification of Disease, ICD-9 and ICD-10. And we calculated standardized mortality ratios and 95% confidence intervals for all males aged 18 to 84, 18 to 64. And in that context, we are only looking at deaths amongst active members, not retired members. So it's an important distinction, and I'll talk about that a little bit later. Also, because there were so few women, we excluded females from this, but believe me, because I am a strong feminist, if there were anything more than 50 or 100 women involved in this study, they would be in the study. But unfortunately, we do not have numbers like that, and so we didn't include them. We used 1996 as the mid-year point for specific death rates for males in the US to calculate expected deaths in our cohort. And we applied a correction for the last age category from 55 to 64 because we know that BMWED members retire at either age 60 or 62, and then they stop paying dues. So we have no way of getting them into the numerator part of that analysis. So we had to figure out what the numbers would be. So we used a U.S. Department of Labor estimate, I think of 11%, 11.2% who were actively employed in that age category. And so we bumped up the follow-up numbers so we would have a reasonably good or a defensible group for analysis. We also looked at standardized mortality in 4 time periods, 1979 to 87, 1988 to 96, 97 to 2005, and 2006 to 14 to assess trends in mortality risk. And the simple reason for doing that was that we wanted to know what causes of death were going up and what causes of death were going down, and what causes of death were more or less staying the same in those 4 time periods. And it's especially important in terms of prioritization to know which causes of death were going up, because they probably indicate that there's still a residual problem in terms of more current exposure, and in some cases the exposures may have, as I mentioned, passed and no longer are relevant if we're looking at the current time. Okay, so here are the findings, and I am going to very briefly try and point to you the standardized mortality ratios, which are in, they're in, I got the red thing, but I can't see it.
That's on the screen, I suspect.
There we go. The SMR, the SMR column is the one you need to keep your eye on, okay? It's a little bit funky here, and I apologize for that, but if you look down, you see that all causes of death have a standardized mortality ratio of 1.63. All of the other non-cancers in this column have risks that are greater than 1.00. The 2 that I want to draw your significant attention to are in the middle. Parkinson's disease and Alzheimer's disease have very high relative risks. The Parkinson's disease is not statistically significant because the lower 95% confidence intervals contains the value 1. All of these others are statistically significant. The ones that I want to pay more attention to as we'll go forward are the ones that exceed a value of 2. Here are the second half of the non-cancers. Chronic respiratory disease has an SMR of 1.89. Liver disease, 1.58, nephritis, 2.50. Transportation accidents has an SMR of 3.27, and as you might well imagine, that is a reflection of the serious hazards of working in a place like railroads, where there are bound to be people run over with train and truck accidents and things like that. There are also complications of medical and surgical events, produces an SMR of 1.83, and suicide, 1.7. Some of these things are very hard to think about and explain from the specifics of a railroad worker exposure. Nevertheless, I do want to share them with you. The next two sets of slides focus on cancers. All malignant neoplasms have an SMR of 1.79, and as you can see looking down the column for SMRs, every one of them has an SMR that's greater than 100. The ones that are the most interesting and significant include esophageal cancer, stomach cancer, colorectal cancer, liver cancer, pancreatic cancer, and lung cancer, all either about 2 or 2.00 or a little bit less. Okay, moving forward. These are the second half of the cancers, again noting prostate cancer 1.93, bladder cancer 1.95, Hodgkin's disease 1.88, leukemia 1.96, and in situ neoplasms 2.11. So we have in this SMR analysis many cancers and many non-cancers showing an elevated SMR rate, quite unexpectedly strong mortality set of findings. Now, this is a set of data that looked at the four time categories. The first one from 1979 to 87, the second 1998 to 1996, 1988 to 96, 97 to 2005, and then 2006 to 2014. It's a little hard to read this figure, but the thing that I want to share with you is that that transportation accidents, which is in blue, can you all see that? Yeah. Right there, is going down. You think that works?
I suspect it's the laser on the screen. Yeah,
okay. So transportation accidents over time is going down. That's a good thing, and it's an indication of a joint degree of serious concern related to trying to lower the risk of transportation accidents. Chronic respiratory disease, by contrast, is that blue line at the top. It is rising, so the risk is greater over time than is the case for transportation accidents. The next one is cancer, and it's also hard to read, but several of the cancers show an upward trend, and we'll talk about them a little bit later as I go forward, because this, as I said, is a little bit messy. Okay. Unlike other studies showing healthy worker effects, this study suggests an all-cause mortality and deaths from heart disease among the union members is 60% greater than the US males. Non-malignant neurological diseases like Alzheimer's and Parkinson's disease with SMRs of 3.1 and 7.1 are very interesting and unexpected in the sense that you might think that those diseases might occur in ages above 65 after retirement, but these were detected below 65. We did a PMR analysis looking at all ages, and we could not find that when you looked at all ages, you could confirm these initial SMR findings in the younger group. So when you do a PMR that includes ages up to 85, you don't see an elevated PMR for Alzheimer's or for Parkinson's disease. Nevertheless, this is of serious concern because it's occurring in adults less than age 65. Chronic respiratory disease presents a nearly doubling of risk with an SMR of 1.89, and this is consistent with some findings in the prior literature, Hart et al. From 2009, who found a link between diesel exposure and COPD among railway workers. Silica dust exposure from ballast may result in some contribution to the elevated mortality from kidney disease and from lung disease. We found slight elevations for silicosis, asbestosis, and mesothelioma in another study, a very small study, but the numbers of deaths were really tiny, so I don't think that they indicate much of anything. Nevertheless, we have looked at them. With an SMR of 3.27, the risk of death among railway workers in transportation accidents is consistent with the hazards that maintenance of way workers have and that they face daily. Our findings of an all-cancer SMR of 1.79 appear to be driven by excesses of cancer of the bladder, pancreas, prostate, esophagus, esophagus, liver, and lung over the 4 time periods. That's what you could not see really in that prior figure. Several of these cancers, including bladder, esophagus, pancreas, and lung, are confounded by smoking, which we could not adjust for in our SMR analysis. But we should also not fail to consider that smoking may synergize whatever the workplace exposures are in terms of the increased risk. We are aware that the calculation of expected mortality depends on an accurate and robust estimate of the number of workers at risk, and it may be that our estimate of the number of the union membership is distorted by the use of one time period, 1996, as the basis for doing the expected and observed mortality. In addition, because we had to move and give an estimate for the age category from 55 to 64, that may also play a role, but these SMR designs are not likely to explain many of the SMRs that were found to be greater than 2 in our study. And our study should be replicated in other railroad unions and in other countries where railroad employment is a large portion of the workforce. So in conclusion, we found many excess causes of death, including Alzheimer's and Parkinson's, cardiovascular and kidney disease, and traumatic transportation injuries or transportation deaths. We found many elevated SMRs, in particular cancers of the bladder, pancreas, prostate, esophagus, lung, and liver, which showed elevated patterns over the 4 time periods. Those should be the ones that we should pay more attention to going forward. As I mentioned, smoking may confound many of these cancer associations, including those respiratory disease, and our study needs to be replicated in other countries where rail industry is important to the national economy. So I want to thank you very much for your attention, and I'd be happy to take some questions if there's time.
David, thank you very much indeed, and thank you for keeping to time. Questions?